Hi, welcome to Urban Renal Talk with Tamika.
And Steve, hello everyone. Thanks for tuning in tonight. How you doing, Tamika?
Okay, I'm back. Am I frozen?
You good now?
I'm good there. All right.
This is live, not memory.
Oh wow. Well, how was your week, Steve?
Pretty good, pretty good. I like to take this moment to thank everyone who prayed for my dad and my family during his ordeal. I'm happy to report that he is out of ICU and on a medical unit, pretty much a heart floor, but he doesn't have heart failure, but he has a pacemaker. But he developed pneumonia, and you know what they say about men, it's hard for them to go to the doctor. So this was building up over time, and times he would push himself through, and some days would feel bad, but I didn't know because I'm not there. My mom was telling me, and Monday, he was having some serious problems that she was like, I'm going to call. And so lucky she did call because the doctor showed us the x-ray fluid buildup in the right side of the lung and basically halfway on the left. And,
Mhm.
they had to intubate him right in the emergency room. So they said if we would have waited, it probably would have been really bad. And my concern, and I'm going to close it with this, is that, with elderly, my dad is 89, and if, patients of that age get in the ICU and get intubated, they can acquire VAP, which is ventilator acquired pneumonia. So
Mm,
you don't want to leave that tube down the throat for a long period of time. So I thank God that he was able to out the next day, and then the day after that, be down on the regular floor, and looking forward to coming home hopefully next week if nothing, no hiccups on this floor. So again, I'd like to thank everyone who prayed for my family and my dad, and I ask you to continue praying.
yeah. Yes. Thank you, everyone. When I got that text, I was like, "Oh shit."
Yeah, and I just thank God that even though I'm injured and all for work, that I was
Right.
available to assist. My mom is 90 years old and she's still
Wow.
around. And, I don't want to be out in traffic and worrying and driving. And so I just thank God I was able to be there for them to,
Yeah.
move along the process.
Right. Thank God that you were there, to be in the room to help them. Because I know your mom was really nervous.
Yeah, she was concerned, but my mom is a faithful woman. She goes to church faithfully every Sunday, and she believes in the Lord Jesus Christ, and she just puts everything
In
in
God's
the
hand.
Lord's hands.
Hmm.
So,
That keeps her from worrying. That's how she got to be 91.
oh, 90.
Yeah. No worrying. Yep. So thank you again, everyone that prayed for Steve's dad and keep his family in prayers.
Yes.
Our topic today is going to be compromise or what they call high risk kidneys.
Or marginal.
Oh, I didn't know that one. Marginal kidneys?
Yes, that's in the article that you sent.
Hmm. Marginal. Wow. So there's some people that would take a high risk kidney. Steve, would you take a high risk kidney?
Well, I do have kidney disease stage 1, but if it got to the point where I had to go on dialysis, it would be a tough decision, but no, I would not take a high risk kidney. And the reason for me is um, the false hope of that high risk kidney. Um, going through to figure out what's the high risk? It could be anything from coming from an 80-year-old person to hypertension to diabetes to cancer in another part of the body,
Mm-hmm.
um, to infection, to HIV, to hepatitis C, B. I mean, it could be any risk to that kidney. And I wouldn't
Right.
want to further compromise or jeopardize my health as it already is. So, no, I wouldn't take one for that reason if I was put in that predicament. How about yourself?
No, I wouldn't take one either, only because I've seen so many patients take high risk kidneys and seeing the rejection rate, also seeing the complications that they have. So no, I would not take it.
What kind of
I
complications did they point, did they have that you
okay.
noted?
Well, some of the complications was the kidney didn't work. The doctor tried to quote unquote jump start the kidney, and the kidney still didn't work. They tried to do apheresis, and the kidney still didn't work. And instead of them being honest with the patient, they kept leading her on and leading her on and leading her on.
Now, when you say jump start, tell our listening audience what do you mean by that?
All right, so we say jump start in the medical field, but what they do is someone that had a kidney transplant, they saying that they're going to wake up the kidney by putting the patient on dialysis.
Okay.
Sometimes it works and sometimes it doesn't. But if being on dialysis puts a strain on your body, what do you think is going to happen with you doing with that new kidney?
Absolutely. And just to piggyback off your comment, I have experienced three patients that received compromised kidneys back in the late 90s, early 2000, when it really wasn't um, out there or prevalent like it is today. So I knew about these compromised kidneys, like I said, back in late 98, early 2000. And that's when these three patients, when they got the opportunity to get these kidneys, I was happy, but I didn't know that they were compromised until after I heard they were sick. And then it's not until they came back, each one at their certain times came back to the unit to restart dialysis. I asked what happened, and they said the kidney didn't work. And this is, I mean, 2 3 months because they had the experience in a hospital, and it complicated matters where they had to extend their stay, and
Yes.
ultimately getting the uh, kidney extracted or removed,
Hmm.
and then healing the waiting for them to heal from that surgery of removing the kidney. So it's a very, very uh, traumatic ordeal to the person, and each one who went through that said they would never go through that again.
Right. Because I honestly don't think like they prepare them for what they're about to endure. Now, for some of them, it works well, but then you only have 3 to 4 years, if that, with it. And whatever that kidney has, now you have, because I know someone that wound up with diabetes because of this compromised kidney. They never had a problem with their sugar before, and they wind up with diabetes.
Right. Now, I was looking at this article by World Report U.S. News Health, written by Michael Schroeder.
Mhm.
And the name of his article was Should You Accept a Compromised Organ for Transplant? And you know, the reasons that they list that some people or the doctor may bring this up to patients on the transplant list are, you have limited options. You
Mm-hmm.
the increasing, you know, wait time for organ transplant,
Mm-hmm.
the donor shortage,
Yes.
and he um, he quoted that doctors and patients must sometimes grapple with accepting more risk.
Mm-hmm.
So you it's almost like you got to compare and contrast with some patients on, do you want to accept more risk in getting this kidney? Some patients may say, they may want to take it to get off dialysis, after probably being on a period of time. But I don't
Mm-hmm.
think the doctors, I don't know, I'm not in the transplant
Right.
office when they talking to them, but when it comes to the nephrologist and the other people on the team, I just don't think that information or education is being fully disclosed so the person can make an informed consent on whether they want it or not based on the information they will get. I'm talking about
Right.
the true information of where the organ is coming from,
Mm-hmm.
what the diet
Lifestyle.
is of that person who had that organ.
Mm-hmm.
And I know you can't only I believe only God can determine how long what organ lasts. But I mean, when you're dealing with scientific and you're taking someone else's organ and putting
Mm-hmm.
it in someone else, I don't want to get spiritual here, but maybe that wasn't originally intended to be. I don't know. I don't want to get into no Bible discussion about that, but I'm just saying that you have some people who may get a compromised kidney and it may last past the 3 years, and it you know you just never know. Just in the case of Chef Chaffee, with he's not taking his transplant medication, I guess, for 10 years, and he hasn't had no problem,
Mm-hmm.
and his numbers are good. I mean, so what works for someone
Right.
else may not work for another person,
Just,
but at the same
right. Right.
but at the same time, you have to be realistic on that compromised kidney. That's where the word
Mm-hmm.
compromise come from. So something is wrong with it. So
Right. So from what I was reading, they were talking about like among the donors of the compromised kidneys, 57% had
well, as Tamika froze up, hopefully she'll come back on. But I want to continue this topic about compromised kidneys. Now, she was about to give us some statistics, and when she comes back, we'll go over that. But let me give you these statistics. 121,409 people in the U.S. were on the waiting list for a transplant organ. Uh-oh. So I'm not sure if we're still on. Let me check my computer to see Tamika's computer shut down. So, okay, we're live. We're still doing this. So, as I was saying, my apologies because Tamika just texted me and said the computer shut down. So, it looks like that I'm still on here. So, I just checked my computer. So, we're going to keep this thing going. as I was saying, according to this article by World Report U.S. News Health, 121,409 people in the U.S. were on the waiting list for a
Okay,
transplant
Steve,
organ. Of that,
where are you?
102,000
Keep it moving. This is live. Things happen.
943
Steve, where
also
you go?
needed a pancreas included with the
Sure.
kidney.
Being live.
So,
Anything
in
can
this
happen when you're
article,
live. So
Dr. David
computer
Klassen,
shut down.
Chief
Anything
Medical
can
Officer
happen
for
when you're live.
UNOS, United Network for
So
Organ
come
Sharing,
back, Steve. Where are you?
says the
Let's see. It's still on.
says that the donor shortage continues to really
Sorry,
worsen
guys. Just give us
gradually
1 minute.
every
We had a little
year,
blackout. Now we're back.
uh, relative to the number of
Acting from
recipients.
the.
So,
Oh.
this
All right.
you
Just
know this
bear
is
with
important
us.
for a lot of people.
If we're
So,
currently live and you're
um,
watching, just let me know that
demand
you
for
can
organs
hear me.
continue to.
Hello out there. Sorry. Have anyone seen my partner? He's on? Okay. All right. Thank you. I just can't see him. All right.
So, um, Tamika and I want to know:
It'll
would
be
you
rough.
take a compromised kidney if you're watching this program?
Oh Lord. You can hear me. Thank you very much. Okay. So just bear with us 1 second. This is what happens when you're live, and we do it live purposely. Oh my gosh, the devil is always busy.
Yeah.
Oh my
So
goodness. That's it.
keep it right there,
Okay.
because I
You
want to
can
see if
see. Okay,
anybody
so the problem
out
is I
there,
can't see
Tamika.
Steve.
I can
So you
see you,
guys can
even though you're
see.
frozen
Yes,
in
I'm
my
on live,
screen.
Steve.
I
I
can
could
still
get a
see
text
you to
message
my
from him,
right on my
but I can't
computer.
see him.
So
So
let's keep this
we're
thing
still
going.
gonna
Um,
keep it
I want to
moving,
know if anyone out there
right?
is listening that's
Or
on a
oh,
transplant
you can see
list.
me. I can't
Would
see
you
you. All I
accept
see is black.
a compromised kidney? That's the question.
Freak. Oh God, this is not gonna work. Thank y'all for your patience. Steve is gonna come back in again. This what happens when you go live. Okay, I see him. We're back, y'all. Thank you.
I was on talking.
Okay, I'm talking over you. I didn't even know. I'm so sorry.
That's okay. We apologize. This is live, y'all. This is live, so expect funny things to happen. But let's continue our important topic of compromised kidneys, because I haven't
Yeah,
seen anyone uh maybe saying that if they would accept one or not. I did have someone earlier today who made a comment that they refused one when they were offered to
right,
get one. They refused it.
right, right. And you know what? That's why they're so important that people become living donors for reasons like that. Because when a person is deceased, you don't know what disease has festered in these organs,
Yeah, that's
and
a good
they don't have enough
point.
time to do a real biopsy where someone could have had cancer in that organ, very small, and then they implant it in someone and it just metastasized, you know?
Very good point, Tamika, because again, they're so quick to probably get those organs out of there, and maybe the person had an undiagnosed cancer or something else that that was undetected.
Right.
Also, we have Tracy on here, And I met Tracy. She's here out of Baltimore. Thank you for watching, Tracy, and
Thank you.
definitely understand that you wouldn't accept one. And there's one hospital that's here in Maryland that does a lot of these, and that's the University of Maryland Hospital, where they have I mean, their success rate for transplant is, you know, great, but they don't report, I don't believe, the, unsuccessful ones. Uh,
Right.
Go ahead.
Is it the implantation rate that's good or the success rate? Because I know here they have how many organs they actually put in,
Transplant, and
transplant
it's
in, but then
probably that.
right, but then the success rate, you rarely see that because each individual is different. And when you're in the inner city, what happens is bodies drop, they pick out and take the organs out and hurry up and try to get someone with the organ just so, sorry, hurry up and give someone that organ just to say that they implanted this organ or met this quota to get more funding to their hospital.
Absolutely,
But
absolutely.
they don't talk about what happens after this kidney goes in. If someone dies in jail, they try to hurry up and get that person to the hospital just so they can harvest their organ, just like they get their organ, not really doing the research on this person enough to call someone because they don't have that much time.
Yeah,
So
yeah,
what they say is it's a high risk kidney. He was in jail. There's not nothing else, like he was in jail. So it's a high risk kidney. But most definitely no, I'm not taking that because it's not enough history on him for me to take that.
absolutely. And before we got interrupted, you were about to share some statistics. Um,
Yes.
57%, and
So
went off.
all right. So among the donors of the high risk or compromised kidneys, 57% had a history of IV drug use. 29% had a high risk of sexual behavior. 11.8% was incarcerated. 7.1% were men who had sex with men. 4.7% have received multiple blood transfusions, and the majority was imported from other centers, suggesting that other places declined the organ. So they were sent from other hospitals and
Wow.
they declined the organ. Yes.
And just it going around like that, I mean,
Yes.
yeah, this is serious. And people, who are on the transplant list that's living in uh, urban areas, urban communities, inner city, need to pay heed to this and
Mhm.
don't, I mean, don't, we're just the health practitioners trying to raise awareness and put this information out there. And all the information that we access is evidence-based material. I mean, you can do the research yourself. Um,
We'll
you know,
put the
just
links
want to make,
up.
huh?
We'll put the links up where we got our information from. We'll just put that up after the show.
Sure, sure, because we want everyone that's on dialysis who wants to get a transplant be aware of compromised kidneys. Uh, I mean, that's your right as a patient to,
Right.
they offer it to you, and
Mm-hmm.
it's your right based on the medical information that you get, so you can make an informed consent on the risk,
Mm-hmm.
well, let me just say the advantages and disadvantages of receiving this type of organ, which is called at risk, high risk, marginal,
Mm-hmm.
compromise.
Mhm.
They may go by names like that. So please be informed, do your research because it's out there. And I don't think it's not enough out there where it's being
Yeah.
talked about, even in the chat rooms, on Facebook, inside the transplant groups. I don't see anything, or it could have been before we, um, developed our show,
Mhm.
maybe in the past, but you know, recently or last, what, 6 months we've been doing this,
Mhm.
8 months. However, I haven't seen nobody talking about compromised kidneys. And again, it could have been on Twitter. It could have slipped past us or been on, but I think it's a definitely important topic to talk about.
Mhm. I think more awareness, like we're not trying to deter people from getting the compromised kidney, but I think it would behoove you to know what you're getting into. You know, that you're going to have to take more meds than someone that has a living donor.
Oh, absolutely,
You
absolutely.
know, it may
And
not work
we,
with someone to go in. You know, there's just so many different situations that can go on from this high risk kidney, compromised kidney, whatever name they want to use for it. There's so many risks with it that they need to be honest and let the person know, well, this is the pros and this is the cons. It's your choice.
right, and one of those articles, the doctor was saying, which I kind of disagree with, that organs such as the heart, um, liver, liver, and maybe pancreas and
Mhm.
the lungs are the most organs to be marginal or compromised because there's not really a long-term treatment
Right.
for those diseases that are for kidney failure. So they're saying in the article that it's not a lot of emphasis, which I found out that's not true. There's not a lot of emphasis on marginal or compromised kidneys
Well,
in
Steve,
patients that, huh?
I kind of see where they're going with it because in order for someone to get someone else's heart, they have to be deceased. In order for someone to get someone else's liver, I'm sorry, not liver, in order for someone to
Lung,
get someone else's lungs, they have to be deceased.
right.
So they are going to be marginal or high risk no matter what there,
Yeah.
no matter
So these
what.
are the organs that are more likely to be compromised than kidneys because, and see, this is the thing. Um, this is a thing that I'm thinking too, where a lot of maybe minorities are not going to be offered the transplants as well because of the dialysis. You can keep people on machine longer,
Mhm.
so that way. Because look, you can see this. More people are coming on dialysis. The transplant list is getting longer, and the
Mhm.
donor rate is getting shorter.
Mhm.
So what does that tell you? I mean, it's outpacing the donor transplant.
Right.
You know, people are
The
coming on.
need is outweighing what they're getting.
Yeah,
Yeah.
I mean, it's going to get to a point where it's going to be so many people on dialysis that their waiting list is going to be, instead of 102,000 or maybe 100,000 on the waiting list, it may be 150 to 200,000
hmm
people.
it's a matter of time before that happen. Like I can see that happen. As long as people aren't aware of living donors and organ transplant, it's it's going to be a shortage.
and that's where the dialysis companies come in to make money. I mean,
Mm-hmm.
because they see that. I mean, I'm sure they do their research and whatever they're doing to, get the numbers to see how many people are actually on the list, compared to how many people are on dialysis.
Right, right. So we have a viewer. She says she's been thinking it over and over, dealing with dialysis, perhaps getting sorry, perhaps getting the compromised kidneys. That means she may be dealing with another illness. Yes. Yep.
It's a possibility. I mean, we're not saying with 100% certainty that that's going to happen, but you have to understand when you have something in front that says compromised or marginal, then it's not going to be like the top as it would coming from a living donor, or from someone that wasn't compromised.
Wow. So she's saying that in 8 years, basically because of her age, based on her age and the length of the waiting list, she doesn't think she'll be called.
You know, that may be true and it may not be true, Sandy. And the reason why I say that, because everyone is different. I knew a gentleman. Well, I didn't know him, but I heard a story of a gentleman got on dialysis, was on there less than 6 months, and got called for a transplant. What I would suggest, getting on multiple transplant lists in New York City, because there's a lot of hospitals up in New York, and you don't have to be on one particular hospital list. You maybe can
Right.
expand out to New York State, New York City,
Mhm.
maybe some other places like New Jersey, which is not far, Philadelphia, places where you can be there within 2 to 3 hours if you get called.
Uh-huh. Yeah, I sure would because we had a patient that got a kidney and shoot, he had to be 79 years old.
Yeah, yeah, I've known a
Yes.
person that was 75 that got a transplant. So,
Yeah.
but the thing is, some places may have certain criterias than other. I don't
Right.
know.
Right. What? Wow. Is only one per. Wow. Read this,
But
Steve. Unbelievable. One list per state.
come on down to Baltimore and try Philly, Philadelphia.
Yes. Yes. That's crazy. That's good. But
Listen,
they do that because New York is so large.
but you see how
Okay.
they.
Kelly has a question for Sandy. Sandy, who told you that Kelly Kel's race say? See it. Kelly Kell Ray. I like that.
Yeah, and see that's ridiculous that if that is true that they only making their list in one state in order to be accepted.
That's so discouraging.
Who
People are
does she
listening
say?
to patients. Kelly Kells told her that people are listed in multiple locations,
Yeah, but
but
she said Cornell and Mount Sinai.
I told her one list per state. I think that's just crazy. That right there is so freaking discouraging. It makes you not even want to get on the list because it's like you're limited of options. Out of all the hospitals in New York, you mean to tell me I come on.
Yeah, and that goes back to what I was saying in the beginning, the limited options. I see something from Pastor Nick.
Okay. Temple University in Philadelphia, right, Pastor Nick? Georgetown University, Johns Hopkins, and two other facilities, one in Miami and the other one. Wow.
Yeah, Pastor Nick, he definitely did a heroic thing. Went came down to DC. That's how I first met him on Facebook Live. He came down to DC and went to Georgetown to get on there, to get tested for someone else. And he told me in Philly he got to run around, and then when he went down to DC Georgetown, man, they just got him through and got everything tested. I mean, just an
That's
awesome
good.
guy to do that.
That's good. Philly probably wasn't for him. It's okay. Everywhere it's not for you, you go right where you needed that. That's crazy. Like, this is why the education just needs to really be out there. They educate on everything else, but not something so serious as this because people don't know.
And it, and Tamika, the thing is, someone I had a guy right, and I'm not going to call any names, but a guy that I know in this community, in this kidney community here in Baltimore. I saw him after seeing him a while. I saw him maybe like 4 months, 5 months ago, could be six. That said he's seen what me and you do, our show and stuff, and he said that sometimes we're a little militant, and that and I kind of chuckled a little bit. He said, "Steve, you got to play the game," because he's up there in you know, like Congress, up on the hill, involved in the higher echelon of kidney disease, being
Right.
involved, and that's good. But when look, whatever it takes, getting loud, being militant, whatever it takes for people to know about this disease and the dynamics and the havoc that it causes in people's lives, from us discussing getting a compromised kidney. When you think if somebody's going to give you the donation of life, you want to make sure you had a life. You don't want to have to worry about accepting, a compromised organ, and you don't know that information, and then other information that is just it's just enormous. I mean, when I say that, how many look, you go on Capitol Hill, they've been doing that ever since they started the kidney disease program. And granted, they got stuff done, but I don't see any decrease in kidney dialysis units. I don't
No.
see any decrease in the transplant list. I don't see any decrease in amount of people being diagnosed with diabetes, hypertension, and kidney disease. All around the world, over 500 million people are dealing with this, and nobody is talking about this mainstream. And just like Kelly Katz Ray said, you got to advocate for yourself. And that's why it's so important for people to understand this. And so I'm whatever, like I said to Meek, if it takes us to be militant to save a life from being on dialysis, from being exposed to compromised kidney that could cause secondary illness outside of the first
Mhm.
illness, if it can help them from having diabetes and not checking it to checking their diabetes and starting to promote a healthy behavior and changing their diet, then I'm going to be militant, because that's what it's going to take. It's going to
Right.
take people like us, advocates, small grassroots organizations, boots on the ground in these communities, steadily talking loud, because if we don't, then at the end of the day, it's going to be sucked up by these dialysis companies, and they're going to have this propaganda that they're doing their best. And, like you said, with the billboard up in Philly advertising their dialysis company, you can come here. It's almost like, okay, if you get kidney disease, which we know it's going to probably happen, you could come here and get your dialysis.
Right. I want to touch back on the militant part. Uh, he forgot passionate. Okay, if we're militant, whatever, but we're passionate. This is real life. Damn Capitol Hill. This is real life. You know,
Absolutely.
you sit on Capitol Hill, nothing is changing. They're
I,
building more and more units. More people are affected with kidney disease. Less people are getting transplants that are viable, that actually last. And then there's no education. And then you have a younger generation that don't know anything about their bodies, taking pills and doing everything else, messing up their bodies. That's going to be the next generation on the machines, and it's not going to last.
yeah, it's
So take that shit to Capitol Hill.
yeah,
Excuse me.
and then it. I mean, then we're not even talking about the diet. You know,
Yes.
it,
Like some type of noise needs to be made. Like wake up people. Like this is real. Those centers that are being put up, it's real. Like they're not educating to stop it. They're actually encouraging. Come to the units. We have warm seats. We have new TVs.
yes, yes, they throw out the amenities that come along to bring you there. And again, I mean, depends on how you look at it. Somebody, comes to a place and they offer you a duffel bag, a blanket, some earphones, um, welcoming you. And even though that's commendable, but at the same time, it covers up, the
Problem.
exactly, exactly. I'm not going to eat, and nobody's talking about compromised kidneys. We kind of railed off a little bit, but since we did, just to add even how serious this problem is, and I mean, when I'm talking about this, I got to go from every angle, you know,
Mm-hmm.
and the other angle is the people that are being hired now.
Mm-hmm.
And when I say that, the companies are going out there just pretty much hiring anybody,
They have to.
hiring
They
anybody.
have to because
Now go
it's
ahead.
it's so many dialysis centers. There's not enough people. There's not enough trained people to be staffed. So they have to grab anyone, train them for 3 months, and say they're qualified.
Yes, and that's the scary thing because practitioners like me and you, I mean, we've been doing this over 20 years, and I mean, it's, it's not like we can't keep doing it another 20 years. I mean, even though there's some people who's been in this field for about 40 years, I know, but I mean, even so, you got people who is just like a any type of work situation when you got people who's been there for a long time that's hiring, that's probably going to another job or just tired of doing dialysis, so they gotta hire people to replace those people.
Right.
And then it's just the people that you get nowadays, they just not really taking this job serious.
Mm-mm. So Erin says that she's been fighting kidney disease since a child, but wasn't educated until she started dialysis. That's sad. If she's been fighting it since a child, education should have constantly been coming to her of what can possibly come.
Well, I think Aaron had a her situation is a little different. She had a different disease, Alport's.
Right. But Steve, even with Alport's disease, if they know that this was the end result of it, they could.
Or they probably could, right, 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 and possibly maybe set up for the transplant
Right.
list or something like that.
Like when my son kidneys failed, Tyrell, his kidneys failed, and within a matter of weeks, they was already working him up for transplant. Thank God it kicked back in, but he wasn't on dialysis a week in him up, and he was 18 months. So it's out there. It's just if they're willing to tell them or not.
Yeah, yeah, absolutely. It is. I agree with you 100%. I agree with you 100%. And, I don't want to call it short of a conspiracy because I don't think that's what it is. But, um, that education is not being out there like it should.
No, no. And then let's see.
Wow, that's
Tra-
30 years.
yes, Tracy, do you mind? What caused your kidney failure?
Wow.
That's a long time.
Yeah, and you're a true warrior, Tracy, and I hope we can
Mhm.
get you on to
Yes,
talk with you. Once you feel better and get out of the hospital.
yes. Wow. Now she's 43. That's a very long time to deal with this illness.
Right, but you had a comment about technicians
Yeah,
that
I'm about to scroll down to that one. Okay, I got it. It's up there. Yep. Some need more
yeah.
training.
Oh, and Sandy, let me just say this on what you said about the technicians going in the same areas. You can actually stop that because that's your arm, and you could actually tell them don't go there, go to another spot. However, I know you may have some concerns because if it may be a new spot that they may not get it. But if that's the case, you should see who the expert cannulator is at your unit or who has the most experience putting needles in, and ask that person to rotate your sites, because if you continue going the same sites, you're going to get what's called a pseudo aneurysm, which is the weakening of your vessel walls, and you keep going to that spot, it weakens out, and the high velocity of blood that's coming through your access is going to stretch that area and develop an aneurysm, which, quote, quote, they call it the knots you may see in people's arms. Um, that comes from repeated sticks in the same area. We used to call it back in the day one site itis,
Mm-hmm.
and they're supposed to actually rotate. I think it's two
Mm-hmm.
finger widths apart on each treatment. They're supposed to rotate, move up, move up. So you have some people arms that you can see where you can go, and then it goes. You can see areas where they never stuck it before, and it's like already kind of worn out in one area.
Right. And me being a technician, I always go in a new spot. They know if I'm coming, I'm going to a new spot because I want their access to last longer. And I always tell them, you have to be your own advocate. You have to look. I know you don't want to look, but you need to pay attention to where people are going in your arm. You know,
Absolutely.
unfortunately, it's a
Very
needle. You
important.
will feel something. I know, and those areas is soft tissue, so you may not feel anything, and you like that. But for longevity of your access, it makes sense that that person move up. And your center should have an access team. Your access team is the person that monitors your access and most likely is the most experienced person in the unit that knows accesses. So if you don't feel comfortable with someone sticking you, it's fine. They don't have to stick you. You have rights.
Yeah, you definitely had a right to refuse and ask for another person to cannulate your needles. And
Right.
then push come to shove, maybe you could learn to cannulate
Get
yourself, which
yourself
a
right.
lot of people are starting to do. I know if I was on dialysis, I'll probably stick my own self. I would.
Right. Let's see. So, yes. Okay. So Aaron said we need to be our own advocates. Yes, you need to be because when you're your own advocates, people treat you differently and they know that you're aware. So they're not going to just do anything to you. They're not going to wait. an hour before putting the heparin in because they know that you're paying attention that the heparin was not attached to the needle or however some people do the heparin. They're going to pay attention that they went through your access and your arm swelled up automatically. That's because they went through your access. So you have to really pay attention and advocate for yourself, not wait for someone else to advocate for you. Pay attention and advocate for yourself. And this is from a
Absolutely.
technician.
But Tamika, you're absolutely right. And maybe next week we ought to talk about possibly things that patients that undergo dialysis should be aware about during their treatment, like uh,
Right,
making sure that they get their heparin 5 minutes before they go on,
right,
making sure that their blood flow rate is at the prescribed rate, making
right.
sure on the
Especially lab day.
rate, huh?
Right, especially labs day. On your lab day, always check and make sure your machine is running exactly where it's supposed to be. Because what happens is your lab scores will drop, and then the doctor, he may not want to redraw it. He may want to increase your time, but it's not your fault. It could have been whomever stuck you.
But you know what? I want to take it even a step further. Some places, what they'll do, and I'm sure you've seen this, is that if a person comes, when they draw labs, and a person comes back with a low KT over V or a low URR, uh, they're going to try to redraw another one before the end of the month,
Mm-hmm.
so they could pretty much has to do with the whole insurance thing uh,
Right.
and reimbursement. But um, I'm not. It's just so many tricks to when it comes to treatment and in these labs. Some places get it right, some places don't, and
Right.
that's what you got to understand when you're dealing with um, even with new people and join the labs
Mm-hmm.
right. And
Mm-hmm.
it's just so many dynamics that can cause a person's URR KT over B low. It could be um, operator error. It could be lab error. I mean, it could be patient error as far as you know what you're eating. But that lab only does it for that particular day. It's not a consensus of the last week or the month. So
Mm-hmm.
say if a person comes in and has something high and what they test for, and okay, they do the dialysis, and say they eat something on the machine, and then they do the post BUN. So
Mm-hmm.
it's just so many factors.
Right. 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 Yep. Yep.
I
I
see another
totally agree.
comment from Kelly.
Yes. She says she always tells new people in the center to learn everything they can about the process so they know what happened. They know if something goes wrong. You're right, because a lot of them, if your arm starts swelling up, they'll still have the needle in there instead of taking that needle out, not knowing they went through the access.
Exactly. Absolutely.
So I've seen that a lot of times where the patient arm is like bruised under here and the access is over here, and the bruising stays for weeks because they went through it.
And I think one of the, let me tell you something, Tamika. I know we're running short, but I think one of the main contributors that causes infiltration, I'm going to tell you, is Russian. And I think now that there's so many people on dialysis and the way they
Mhm.
got the process going, they create the environment almost like a rush environment. It's like you have one chair empty, and then say you have two patients on, one chair empty. Patient may got 10 minutes, one may got 20 minutes, and you try to bring in the next patient, And once you get everything set, the patient gets sit down. The other, time has moved on, so patient may have 3 minutes, and you know that, and you're trying to get this patient on, so
Mhm.
when the machine goes off, you can go over there and take the other person off. And I think that's where it's a majority of the infiltration, because they're rushing, they're not taking their time, they're not doing the access um, assessment. You know,
Mhm. I was gonna say that.
look, listen, feel. Listen with your stethoscope, feel with your
Mhm.
hands the brew and the thrill, and look at it for any redness or infection or anything, and take your time. This is even though we do it every day, day in and day out, but to the person that's on the other end of that needle, this is traumatic.
Right. And another thing, Steve, as a technician, another thing that I noticed throughout the years is following behind someone's needle tracks, the dot. And though it may look like that access is going left, it may actually go right.
Right,
So
because
they're not
again,
filling.
yeah, right. They could have
So
lost
they're
in the
right, they're following
back.
behind someone else's tracks instead of actually taking that second to fill their access. First, asking the patient to watch their arm and then fill their access to see where it starts and where it ends.
Oh, absolutely, absolutely. That's very important. Hand washing, and that's the number one thing with your access. Please make sure when you come in the unit, before you get on, that you wash your access, because this is another thing that you may not notice or you may have noticed. In a lot of the big facilities, some places used to have alcohol pads that were about this big. Now they shrunk down to a smaller pad,
You
and
notice?
they're not really wiping the arm. They may go like this real fast. I
Mm-hmm.
seen that,
That you're
and
supposed to go
right,
in
and it
the
starts to
right,
move in and out. You start from the
right,
inside and go out. But
right.
the
And
thing
alcohol
is,
is supposed to be stuck wet.
again, it's this created environment that that is created by the company to hurry up and get the person on. So you can get
Right,
a pack. You only may have two alcohol pads in there, real small ones, and they just may wipe it and put the needle in. And again, you can get infection through that if you're not cleaning the arm off well.
right. Okay, Anthony, another part of being your own doctor is making sure you set appointment with the doctor. Yes, we call it roto-rooter to have a fistula granted. And people don't understand when they bleed excessively, there's a problem. They think it's the technician. Well, sometimes it can be, but they think that it's the technician, but there's an underlying issue why you're bleeding so much. And there could be some stenosis growing in there. You may
Yeah,
need to really
of your
joint.
of your access.
Yes.
And
And
I
they'll never be afraid to tell a technician no.
Oh, absolutely, Anthony. I agree with you, buddy.
Yes.
100.
Because when I hear no, that means it's a break for me to go get some water and come back. And by then you'll be on the machine. So I don't take offense to no. I use my time wisely.
Yeah,
Wash,
yeah,
yeah, yep. And not just washing your access, guys. When you're home, when you're preparing to come to dialysis, with that arm, there's no need to put lotion on it. Like, don't put anything on. After you wash it
yeah,
with soap and water, just let it dry.
yeah,
Because a lot of times, that's all we're doing is wiping off whatever you put on.
yeah. The lotion, any
The
type of
oils,
cream or Vaseline. Vaseline attract the petroleum. Now, this is one thing with Vaseline. Petroleum, that's the stuff that's used like airplane um, um, fuel, like petroleum. Now, you see how thick it is. So when you put it on your skin, that stuff is absorbing through the skin, but at the same time, it's attracting dirt. Um,
Right.
and if you got Vaseline on and you sticking that needle in, you put yourself more at risk for a access infection, bloodstream infection. And this is another thing, Tamika. I know we got off the rails,
It's
but
okay.
this is important information. Please, please, if you're listening to this and you're doing dialysis, make sure they're putting a sterile 2x2 over your site and not just tearing a piece of tape and putting it over the needle.
Yep.
Yeah, I mean, I, I'm not going to say where, but right now, I know right now a lot of places that they put the needle in, okay, they tape it, then they do the butterfly, and then they put another piece of tape over the needle part instead of a gauze. I always put gauze over. That was old school. Um,
Right. So we
but
use band-aids up here. We use band-aids. We use
oh,
band-aids, then the tape, then the butterfly.
okay. Well, but you cover the site, right?
We cover the site, yes.
And so my point is, you got some people that may have coaster pockets that may keep tape in their pockets, or have it, or the tape may be sitting around on the counter or
For
whatever,
pain,
and they may use it um, for that patient. Not everybody is going or have a area where they're taking that tape off and putting it on the strip and doing the right thing. And
right.
so I encourage patients undergoing dialysis to have your technician put a sterile 2x2 over your site instead
Mhm.
of just regular paper tape or even the plastic tape, because that tape breeds infection. The tape is
Mhm.
not sterile.
Yep.
So
The adhesive. Also, Steve, there's a cream. I think it's called Emerson cream that
you
the
talking
patients use.
about Emlyn?
Emlyn. Yes. Listen, you guys, if you are using that cream, pay attention to how your arm is deteriorating. They're not talking about it, but that stuff causes infections and it
Really?
changes. Yes. So, Steve, next time pay attention to how the patient arm looks. It makes the skin really soft. It changes the color of the skin. Pay
Okay.
attention. And then they start to get I'm up here looking at my arm like you guys can see me. They start to get a rash just in that area.
A lot of people that you've seen use it, or just a couple?
No, a lot of people that I've seen use it come up with this rash, and they come up with discoloration of the excess. And when the excess get really soft, they're still using it. So guess what's going into their excess?
The cream.
Exactly. And then they wind up with a really bad blood infection, and they have to get rid of the excess, and they thinking it's the technicians not properly washing their hands, but it's this cream.
Wow. How did you discover that?
Years of watching and paying attention and nobody listening. So I sit there and I watch the people that get this cream, and I tell them that it's going to break down their skin. They don't believe me. So when I start seeing the skin changing, I come and tell them, I'll be like, look at your skin. Look at your skin. And when it gets really bad, when they get the aneurysms and going in the same spot to where as though it's not closing and they still put it on and they wrap the saran wrap with it, it's just going
Right,
straight into their bloodstream.
right, right, right.
Yep.
Wow. I mean, that's just bring up a whole new, you know.
Yeah. Yeah.
Yeah. Well, one thing I do want to say that I just thought about that hasn't been talked about. If you have kidney disease, or if you're in one of the stages, um, just kind of check your deodorant, because a lot of deodorant has aluminum in it.
Yes. Yes, yes, yes. And not just the deodorant has aluminum, you have to wash the lotions and the soap. And there's a soap out there that's really good for dialysis patients. It's by Dr. Bonner. It's Castile soap. It's all natural. Castile soap.
Yeah, put that up.
I'll put a picture of Dr. Bonner, and
Oh,
it's
okay.
better. Yes, she don't use the cream anyway. Good, don't use that cream. That cream is the devil. Though it numbs your arm, but I've seen it do some things to people. Yes.
Right, right. So again, the question is, would you accept a compromised kidney in this day and time, being with the shortages of kidney donors and long list of patients waiting for donation is pretty much getting longer and longer each year. Would you accept a compromised kidney? Um, we had what? How many people said no? I think two. Tracy.
Yes, I will. I'll put the soap. Probably not. Erin said probably not. That's just her.
Okay.
Kelly Kells, would you accept a compromised kidney?
Is Anthony Baltimore? Would you accept a compromised kidney if you're still watching? Yeah, Tamika. This.
Kelly Kells said nope.
Yeah, this. You know, I know we've been doing interviews, but this is, you know, education time is coming up, and what would have been a good topic tonight that we can wait till next week. But a good topic tonight would have been
Anthony said no.
emergency disaster.
Yes, especially with the storms. You
Exactly,
know, make
exactly.
sure you have your K-Exolate. Do anyone know what K-Exolate is?
Especially down in North Carolina, a lot of people who had to evacuate, over 1 million people or more. And how many of those people were on dialysis?
A lot. Remember what happened in Katrina? A lot of those dialysis patients died, but they didn't say anything about them. But a
Yeah,
lot of those patients died.
and even in Puerto Rico.
Yep. Yep, a lot of them died. You didn't hear anything about it because it's this hidden disease that no one wants to talk about. So they don't talk about those that's affected in the hurricanes who have to go to dialysis.
I
So
just
always prepare yourself.
Always. Especially if you living in those areas. I just saw a comment from Sandy that said they try to sell you on the compromised kidney.
Let me see. Yes, they do. They do, and they're not supposed to. We just read an article that said that the doctors are not supposed to sell you on getting this compromised kidney. It's your choice. So she says she still's on the on the fence. I understand, because of your age, I do understand. But at least know your risks. Before you do it, know your risks. That's it. We don't want to discourage you. You're gonna, it's your life, but just know your risks. Be educated on what you're about to walk into.
Yeah, so you could make a informed consent.
Right. And not just that, so you have questions. Because one thing with doctors, they don't like questions. So when you have certain questions, they'll shut down and go to someone else versus answering your questions. They won't try to use you as a guinea pig when you have questions when they see you are an advocate of your own self.
Absolutely, I agree with you.
Mm-hmm. So, wow.
A few people I know died in PR from no dialysis.
Hmm.
See, that's ridiculous. That is absolutely ridiculous.
But see, the news didn't talk about the patients that was on dialysis there. They didn't talk about the patient that was in the Virgin Islands. They don't talk about the patient that was on dialysis anywhere.
That's why we gotta get loud.
You know,
Gotta really get loud with this. But
sound the
maybe next
alarm,
week we can
something.
talk about that disaster emergency disaster, because I do have a book on that, and from Medicare, and it gives you
Right.
all the information what you need to prepare, and that's really important, because think about the people who lives in urban communities down in the North Carolina, South Carolina, who don't have transportation, don't have access to um, finances or resources, or got to go into a shelter, and then the clinics down there, if it's going to be as bad as today, what about the clinics? They're going to be closed. We had up here in Baltimore when they first started talking about that storm, and our governor put us in a
State of
uh,
emergency.
yeah, they started talking about closing units down, and here you go now. Here it is today, and the storm's not even coming up this far.
But people need their dialysis. I can see they say everyone gets 3 hour treatment, you
Mm-hmm.
know, and they try to get everyone home before the storm. You may have to get dialyzed on a Sunday, but to actually shut it down,
That's what they're
or
talking about. I'm sure things changed since further, coming in the week, and keeping um, track of the storm and seeing how it's not going to make it up this far. I'm sure things have changed,
Mhm.
but yeah, when they first did it this week, I talked to a coworker who said that a particular company was already starting to try to rearrange days.
Right. So Sandy wants to know what medicines should should she be aware of in case of a disaster? Well, Sandy, you always should have your prescription. So once you start going low or halfway through with your prescription, I always tell my patients to put in for a refill because
Right.
the pharmacies may not have your medicine and you may have to wait a couple days. So if you have half a bottle or 15 pills left, you still have enough to get you to when it comes in. And then they should give you something called KXLate.
Can you tell her what that does?
KXLate binds all the phosphorus and everything, and it comes out in your, excuse me,
Potassium. The potassium.
potassium in your poop. And you need that because too much potassium could kill you.
Yeah. So in most places normally give
And
a
take your
prescription.
binders. I'm sorry, I did get that messed up, but take your binders. Please take your binders.
Yeah. Yeah. Most places they give a prescription for the K-Axlate. It's like sorbitol SBS, and you take it, like, I believe I want to say 30 cc's, or it's like 15 grams or something like that. But you take it to help eliminate, or if you can't make it to dialysis, and you eat it, but like Tamika said, it binds the potassium into your stools and help you eliminate the potassium out of your body through your stools.
Right.
So
Yeah, this
so
is good.
yeah, this is really getting serious, and we got to figure out a way. Oh, and if you can't get a laxative, well, not any
Hmm.
laxative, because I think it's the ingredients in the K-Xlate that bind potassium to the
Mhm.
to the stool to help eliminate it. So not any laxative would do. This is something that you over have to get a prescription for.
Right. And it's always best to, always have it in the house because you never know, things happen, disasters happen. But when you know a disaster is coming, get it and remind them about it because they may not be thinking about it, but it's your health, not theirs. They clock in and out. You live this 24/7.
Absolutely. Absolutely. Well, I know we ran over 24 minutes over, but the information is very important. Sometimes we stop at 10, sometimes we don't.
Right.
Um, Today is one of those days because the nature of the topic. We covered a lot today. We talked about compromised kidneys. We talked about being your own advocate. We
Mm-hmm.
talked about preparing your arm for dialysis and making sure that they don't stick you in one site, rotating your sites, checking
Mm-hmm.
your. It's so many dynamics to this disease that we can't cover it in one show, two shows. This is something that has to be an ongoing process because
Right.
kidney disease is not going to stop. Once we die or leave this earth, I mean, it's still going to be going. And that's
Right.
why we need advocates out there to speak loud and clear about this disease.
Yes.
We're going to
And
continue
all
to do this.
right. And even though there's so many different organizations that spreading awareness, we are all working for one common goal is to spread awareness about kidney disease. Because the more awareness we spread, the more people we can help, especially the next generation.
I agree. 100%.
Okay, so some of the things that we talked about tonight, I will be posting it on the page on the Urban Kidney, sorry, on the I can't even think right now.
Talk with Tamika and Steve.
Yes, I'm feeling a little nauseous.
All right, that's okay. That's okay. I feel in the
Yeah,
blank.
yeah, thank you. But I will be posting on the page momentarily.
All
So
right. Well, we'd like to thank everyone for tuning in and watching our show. This has been a really great show. And we look forward to seeing y'all next week with a new topic. And another, we may have a guest, we may not, but we look forward to having a guest to discuss the topic we will be talking about next week. Until
yes,
then, thank you for tuning in. We see you next week. God bless. Thank you for tuning in with Urban Renal Talk with Tamika and
yes,
Steve. Good night,
yes.
everyone.
Good night, everyone.
See you, Tamika.
See you, Steve. Great show.